I'm going to be taking questions at the end of this presentation. In patients with family history of genetic cancers, or those who are otherwise at high risk of pancreatic tumors, having the latest innovations and resources for identifying and tracking these tumors makes all the difference in every part of the treatment program. Since we're trying to avoid radiation and biopsies at any time, we use ultrasound screening as the first-line scan to image the pancreas. If there's anything suspicious, we can employ the scanning feature that tracks the hardness of the cancer, where benign tumors are generally soft and cancers are generally rock hard. If the ultrasound component demonstrates hard tissue, then the likeliness of cancer is high and the area needs to be biopsied. Image-guided tracking of cancer is used internationally. When I first started in radiology, I finished my residency by going to Denmark to learn how to do image-guided biopsies under ultrasound because this was not being done in the United States. Later, I went back to Europe to learn blood flow imaging, which is turning out to be the most accurate way of measuring cancer aggression. The yellow eye is jaundice, and that's often the first sign of cancer of the head of the pancreas because it blocks the green bile duct. You can see the rest of the pancreas is not connected to the bile duct, so cancer in these clinically silent areas often have no symptoms until it causes severe pain from wrapping around the blood vessels and nerves in the middle of the body or has metastasized. In this single-shot sonogram, the head of the pancreas is labeled with 2 arrows. The body in the middle lies over the big blood vessel, the aorta, which we can see in seconds with high accuracy. Now, the accuracy depends not only on the experience of the person doing it, but also the equipment and the body habitus. In other words, with very thin people, you get great images of the pancreas, and in very heavy-set people, we often have to resort to special imaging with ultrasound. More commonly, CT is considered the main way of imaging the pancreas in general practice. As I mentioned, the vascular landmarks are key because the pancreas surrounds the great vessels shown in red, and the stomach sits right above the neck of the pancreas. This is like a slice down the middle of the body. So it's a different orientation. You need 2 orientations in any imaging procedure to localize the cancer and triangulate the effects of the cancer on the adjacent organs. Surgical landmarks show the liver on top, and the arrows indicate the central duct of the pancreas. This is not the bile duct. This is the pancreatic duct, which is different. In this case, a simple ultrasound over the abdomen shows that it's 2 millimeters thick, as thin as a dime. Note the teardrop black vena cava, which is the huge vein in the center. Again, the vessels are the key factors because tumors that invade tend to block the great vessels. This is in French because the French perfected the pancreatic treatment using chemotherapies. By using chemotherapy, they were able to shrink the generally large tumor by the time it was diagnosed as something that was operable. If it is sparing the aorta, a great blood vessel, or invading the great vessels significantly, this is considered non-resectable. Fortunately, advanced therapies can shrink it, so a resectable tumor can be extracted from a non-resectable mass using radiation chemotherapy or other cancer treatment technologies. Resectable means that it is operable. That is, if it's hitting the next 2, but partially and not completely invading the aorta or the vena cava or other major structures in the middle of the abdomen that the pancreas surrounds, you can cut it out with a scalpel. Staging in 2019 uses other cancer markers and a more personalized approach based on the patient rather than on a formula or a paradigm dictated by the medical profession that strategies a standard treatment approach. This now includes gene testing and advanced vessel imaging technologies which measure and quantify how many tumor vessels are invading the area or how many cancer vessels are supplying the cancer and making it grow. Once you find that a mass contains lymph nodes, we have to see if it's an abnormal lymph node. And then what part of the lymph node is abnormal? Is it inflammatory? Is there fatty replacement? Are there two lymph nodes stuck together? So the ultrasound is the simplest way to study the lymph nodes because the patient often will take the probe in his or her hand and put it over the area that's hurting or growing fastest. Because the sonogram can target the biopsy, we can check which part of the mass, be it in the arm, groin, neck, or any other place in the body where lymph nodes tend to recur and are accessible from the skin surface. So this excludes deep lymph nodes in the pelvis, or those around the great blood vessels that have to be imaged by CT or MRI. We target the lymph node by doing image guidance to advance the needle into the most suspicious part of the biopsy site. Guided biopsy under ultrasound is the best way to extract the cells and get a better diagnosis. This means that you do not have to cut out the whole lymph node and send it to a pathologist. We put a tiny needle in under sonogram guidance, or CT or MRI. We extract a core of cells and give it to the cytopathologist who's sitting in the same room for immediate pathologic confirmation. Looking ahead, the cancer organizations are now focusing on tumor biology and cancer marketing. There's something called radiomics, which is using radiology and the appearance of the image to decide how aggressive the tumor is. Now, radiomics means the size, the shape, and the vessel density or tumor blood flow can be measured either by Doppler ultrasound, by contrast CT, that is CT with dye, to show the blood vessels going in, or contrast MRI, which again is another way to look at the vascular tumor. And tumor vascularity is the best marker of cancer aggression. This is so important that when we treat cancers, we use the blood flow to see if whatever treatment they're using has killed them off, such as in freezing or radiation or with the new laser treatments. The other part of radiomics is the hardness of a tumor. Cancers are usually hard, and this is called the elastic property. So radiomics in cancer imaging encompasses many aspects of imaging features. Cancer often goes to bone and frequently to the spine, the rib cage being a very common area. This metastatic focus to the eighth rib is clearly seen with the red arrow pointing to it. The image to the left of that shows tumor blood vessels, and then in the bottom right is something that is called a histogram, indicating a vascular index 47%. This is a measure of how many cancer vessels are in this particular area, which is again a measure of aggression, a quantitative indicator of how aggressive a tumor involvement is in this volume. The vessel histogram technology uses 4D imaging. This means we look at a tumor in real time. 3D imaging shows the entire tumor, and in the 4D aspect, we search around the most aggressive area as seen on the left side of the picture. 2D Doppler simply shows blood vessels and shape, and the right 4D image gives you an indication of the tumor biology in a moment. The red part is vascular, the dark part is cystic or avascular. And more importantly, if something is avascular or cystic, there are no tumor vessels in it because the tumor in that area is dead. This is an example of the use of vessel density. In this case, there's a patient with a previous cancer. There's a large mass under the arm. On the top right, if you put a needle into the vessel density 1%, you're going to get useless bloody fluid. If you put it into the area that's 27% vessel density, you're going to get usable pathologic material instead of an inconclusive biopsy. You're going to get cellular material for tumor markers and genetic analysis. Histogram vessel density imaging takes only minutes to perform on a computer workstation and is a process that's used worldwide. An example of cancer treatment being adjusted or followed and analyzed by tumor vessel imaging is adenocarcinoma, which is the usual cancer in the pancreas. The graph shows the vessel density at 32.9%. This patient opted to be treated with complementary methods. A lot of people come to me because they refuse surgery and want to try natural or minimally aggressive alternative or even experimental treatments. We can see that 6 weeks later, the alternative treatment worked because the vessel density went down from about 33% to 5%. As a follow-up 2 months later, the patient stopped the treatment and the vessel density shot up back to 23%. So this is a quantitative means of non-invasively telling if a cancer therapy is working or is not. And it's a real-time validation of success because you've got the tumor and the treatment effect in front of your eye. Genetic testing overall has 60% accuracy. For example, the study from Memorial Sloan Kettering showed in melanoma diagnosis, it was a 55 to 63% accuracy in a year-long study. Gene tests in the pancreas have similar accuracy to clinical testing. Your risk is increased if there is a BRCA gene positivity in the family, or there's other genetic family syndromes such as the Lynch syndrome and the Peutz-Jeghers syndrome, which caused a high incidence of gut-related tumors or GI cancers such as colon cancer and small bowel cancers. Now, in the rest of the world, other technologies are used. For example, in 1974, when I trained in Denmark, the surgeons there were doing imaging. They were actually putting needles into a pancreatic mass through the skin with local anesthesia to get the sample of the tumor. This was forbidden in the United States until 1999, and even now used sparingly. This slide shows that the pancreatic tumor can be seen with multiple technologies. The bottom image on the left, A, the green area shows that the tumor is benign or fatty tissue. To the right of that is a small dark area on the sonogram. And interestingly, the last image, D, is done with a handheld portable ultrasound unit that shows a 1 centimeter mass deep in the body of the pancreas. Contrast ultrasound is also being used all over the world, and it shows the cancer vessels where the tumor vessels feeding a cancer are. In this case, a pancreatic tumor, and the blood flow shows up in seconds following intravenous contrast, which is safe. So unlike the CT or MRI contrast, there are no side effects from contrast ultrasound injection. The contrast MRI shows the white arrow pointing to a huge pancreatic mass. This is the common way that pancreatic tumors are assessed using MRI and contrast to show the location and pre-surgical planning of pancreatic cancer procedures. CT staging with molecular biology or radioisotopes is used to find the tumor and to stage it. In other words, the PET-CT scan is a radioactive tracer study to show where the tumor is and if it's getting better. And example A on the left, you see the tumor under the arm, and the follow-up study some months later shows that the tumor has spread. This is an indication that when you look from one black tumor dot to 3 larger tumor dots in the same treatment, then the therapy needs to be readjusted. With elastoendo ultrasound, benign tissue is green, the liver tissue is blue. This is a technology that's been used for 30 years in Europe. And in cancer screening worldwide, it is being used to avoid biopsies in the breast, the thyroid, the skin, the prostate, the pancreas, and liver. It is highly accurate and used as a primary screening tool more and more. So elastoendo ultrasound means you're putting a tube in like an upper GI series or an endoscopy, where the tube goes into the duodenum and uses the probe to image the affected area of the pancreas. While this is an invasive procedure, it avoids biopsies sometimes. Teamwork helps to get the job done, even if all the participants involved aren't necessarily individually and separately compatible. But as a team, it's a way to go. It works very well. Thank you.